Thank you for the invite to the meeting. It's been great to be here. So I'm going to talk, I understand the theme of the conference is related to AI. So I thought I would talk about how this will impact coronary assessment with a variety of intracoronary imaging modalities, CT, OCT, and IVUS. I do have a major conflict, and that is I did use AI in the preparation of this talk. So what I'm going to go through today is why AI is important and why it's important that we do, as interventionists, adopt this technology. I'm going to talk a little bit about current uses, how we're making use of it at the moment, and then touch upon future directions, because this is coming to us and we need to be aware of its utility. And then the most important slide will be the last slide, which is the pitfalls. And for any adoption of new technology, it's very important we know what the limitations are. So why is AI important in coronary assessment? Now, we could say we're great imagers, we don't need this. But actually, anybody who's done any sort of research in imaging, those drawing circles is really tedious. It takes your time, and if we can find something that does it automatically, then why not use it? It reduces operator variability. That's important. And as increasingly we're doing precision PCI, we need to have precise measurements, reproducibility, and it will eventually, with adoption, reduce the learning curve. So I'm going to just touch on how we're using it at the moment. So the role at the moment predominantly is for measurement automation. And we've got software that we're all familiar with where we're using this on a daily basis. This is an example of the Ultrion software where you can see that quite nicely all the measurements are drawn up, the amount of calcium, the arc, the length of the lesion, etc., and that's done automatically at the touch of a button, whereas previously we were having to look through. And then for those who have it, the AVVIGO software with IVUS, also similar in allowing us to automatically get the lumen size and get the length of the lesion as well. And it can give you a vessel profile and it also vessel composition with the amount of calcium, etc. And with CT, we already use AI. So those who have access to CT-FFR know that CT data can go off somewhere and come back with FFR measurements. And that, again, does make life easier in terms of managing patients. But the question is, what's the next step? That's what we're using at the moment. And the next step, which is currently in development, is the integration of physiology and anatomy. So if we've got anatomical data, we also want to know whether it's functionally significant. And you can get AI-derived FFR, which will tell us whether or not we should do a lesion. So this has an impact on strategy. So if there's unnecessary stenting, it avoids unnecessary stenting. And so therefore we're moving from just lesion automation to strategy guidance with with combining functional data. And we have this already. So there is the IFR co-registration, who some may be familiar with, and that does combine functional information from the IVUS runs there with IFR to tell you where the most significant lesion is, and again allow some estimation of stent size, etc. And going on from that, there are developments to allow functional assessment via AI-derived parameters from anatomical data with OCT as well. So this is OCT VFR. So this does not need a separate pressure wire assessment. This just takes the anatomical data and gives you an FFR there, and you can see a 0.67. So that's important both for procedural planning, strategy. And then going on for why we do the lesions, AI can also guide us into what is the most important device strategy. We can use the anatomy combined with the physiology to decide whether we need to do a lesion and also how we do that lesion. So already we've seen the calcium distribution as a guide, and that combined with anatomy is powerful. And the future is that our AI will dictate to us whether or not we need to do calcium modification, rotablation, etc. So it can target our strategy to actual lesion morphology. And we can already do this with CTCA. And those who are experts in CTCA know that the information from calcium can give us an idea of stent size, stent length, potentially, and also additional anatomical data from the aorta, such as what guide we should use and how our wire is going to behave. And we're all looking forward to the results of the P4 study, which is a randomized controlled trial of 1,000 patients that's just completed, comparing CT as an approach in which the strategy is guided by CT versus IVUS in terms of calcium modification. Okay, and I've already mentioned ultra and calcium detection, and that also can help with procedural device selection. And as you're aware of, I don't need to go through this, that the amount and distribution of calcium will show us, will suggest which calcium modification technique we should use. And then moving on from that, so we've decided how we're going to do a case. We've decided whether it needs to be doing, and then after the stenting procedure, AI can potentially tell us whether or not we've done a good enough job. So post-PCI FFR, I don't know many people who do that routinely. Anyone in the room who does post-PCI FFR? Okay, one. It's very rarely done, and that's because it involves instrumenting the vessel again, another pressure wire. So actually, we all know it's a good thing, but people use it. But if you could press a button and the machine could tell you what the FFR is, then we're likely to use it and optimize the results. And again, that can be used from your post-PCI anatomical imaging to give FFR data. And the impact of that is if you've got a borderline FFR, then you're more likely to go back to improve it. Okay. And then just moving on from that, AI can then help with disease management after the PCI, because obviously management of coronary disease is not just purely about the stenting process. So AI can be used for risk stratification and follow-up. And there are models which can tell us plaque burden and a residual FFR drop, and then predict long-term event rates, etc., from this combined data. And what it suggests is those patients who may still have a low FFR and a high plaque burden may benefit from intensive lipid lowering, risk factor modification, and maybe closer imaging follow-up. And this extends our management of coronary disease from PCI to long-term management. And I know we love the stenting procedure, but this is equally, if not more so, important for our patients. And then in terms of long-term management, there are other technologies which are available and which are being developed, which can also help. And with the integration of AI, there could be guidance, say, from a CT scan, a fat attenuation index. Has anyone used a fat attenuation index to define? Nope. Yeah, so a few people. So we can send these off the CT scans and get an indication of perivascular inflammation. And the suggestion is that these patients would do better from intensive lipid lowering. So if we could do that for our patients, then we can manage them better in the long run. And going on from perivascular inflammation, other things that will be available are AI lipid detection. So we're talking about inflammation, we're talking about vulnerable plaque. We know these are all areas that we inadequately understand at the moment and potentially have a great impact on our patients. And it may be that with our intracoronary imaging, we can then get an idea of vulnerability and be able to act accordingly. So we've done a thorough assessment guided by AI. We can use AI for lesion preparation, planning, optimization, and long-term management of patients. And then we treat the patient according to the information that we've got from AI and verify the result as well. And as I've mentioned, we can then adapt their management long-term to reduce their overall coronary risk in the future. So what are the next steps? We've gone through the current technologies, we've gone through what is being developed and what the future looks like. The next steps are important, as without validation, there is no point in having these technologies, and everything needs to be rigorously tested and reliable. We know there are errors in AI interpretation, so we need to ensure that they don't impact on our patients. We also need outcome data. So I've already alluded to the P4 study by Carlos Collet. So that is AI interpretation of CT versus FFR, and that will give us some data on the reliability of that strategy. It has to be user-friendly. If you're still having to press lots of buttons and add a lot of steps, and nobody's going to use this technology. And the most important thing is that this is not something that you can just use without being trained on. It is very important that the training is extensive. And the reason for that is because there are pitfalls to AI interpretation. And without knowing those, we're going to potentially do harm to our patients. So if you look at that OCT image, what it's suggesting is that there's calcium there that's 101 degrees with thickness of 51 millimeters. For those who do OCT, you know that's not true because all it is there's inadequate clearance and therefore it's actually very difficult to interpret those images. And you can't make any interpretation. So you need to know which images you can interpret and which you can't. If you look at the second image of the CT, there looks like a potential lesion there. For most of us, we'll know actually there's an artifact there, but unless you've looked at the images, you won't notice that there's a line artifact through there, and that is an inaccurate result. So that may come up as an FFR of, 0.5. But you do need to assess the images. And then the third image there is a case that I did myself a few weeks ago, once I was becoming familiar with the AVVIGO. I mean, there is a learning curve, and because I've trained without AI, I do sometimes switch the AI off because I want to just have a look at the images without it. But if you look at this, the image there, it gives you a minimum diameter where the tightest lesion is, and then it automatically puts some markers either side. Now, if a technician is doing this for you, and you say, tell me the stent size, they may just say, well, it is 11.3 millimeters is where the lesion is. Actually, that is completely wrong, because unless you know the technology, you wouldn't know that those markers are actually to a 50% plaque burden, not normal to normal. So you need to be aware of that. And unless you actually go back and look at the images and decide on stent size. So there are obviously pitfalls that you need to be aware of. So just to finish off, I'm just going to mention some take-home messages. AI is evolving. So whereas predominantly it's used just purely for measurement automation, it's evolving to strategy guidance for us. Evolution will decide how and why we do a procedure and also suggest long-term management. So this all sounds great for patients. But it's only to be used as a tool to enhance. And this is where the risk is. It will never replace clinical judgment. So you need to know your technology, you need to know your pitfalls before you can make decisions. But there are advantages. It can reduce improve workflow, reduce variability, and support training. But in order to be able to use it, we need to be engaged with AI development. We need to follow the story. We need to see the various iterations. I can only use the AI now because I know how to use the imaging without the AI. So I'm aware of what's normal and what's not. And that, just to finish off on my final point, that just be aware of the pitfalls as to AI. So it's coming near to all of us soon, and we need to be prepared. Okay, thank you.